Colleagues, we are looking at a masterclass in resistance. This is a DTR Pseudomonas aeruginosa, difficult to treat. And for many clinicians, this susceptibility report would look like a dead end. But as specialists in gram-negative resistance, we know that the molecular nuances in these secondary panels are where the battle is won. Let's analyze the wreckage of the standard panel first. We have high-level resistance to cefepime, zosyn, and the carbapenems. Most notably, we have a ceftazidime avibactam MIC of greater than 16. When Pseudomonas breaks through avicaz, we are often looking at a complex interplay of AMP-C hyperproduction, efflux pump upregulation, and OPRD porin loss. We see an intermediate MIC of 8 for ceftolozane tazobactam. While Zerbaxa is often our workhorse for MDR Pseudomonas, an MIC of 8 is a danger zone. Even with high-dose extended infusions, we are flirting with the PK/PD ceiling. We need a more reliable target. This is where the specialized panel changes the game. First, look at imipenem relebactam, or Ricarbrio. It is susceptible at an MIC of 2. This is a fascinating clinical pivot. Why is the isolate resistant to ceftazidime but susceptible to ImiRel? This tells us a lot about the resistance mechanism. It likely rules out a metallo-beta-lactamase. Instead, it suggests that the relebactam is successfully protecting the imipenem from the isolate-specific class A carbapenemases, or hyperproduced AMP-C, even where avibactam failed. However, the absolute gold mine on this report is the cefiderocol result, an MIC of 0.12. In the world of salvage therapy, that is an incredibly beautiful number. Cefiderocol, our Trojan horse siderophore cephalosporin, is bypassing the porin channel mutations and efflux pumps entirely by hijacking the bacteria's own iron transport system. At an MIC of 0.12, we are well within the therapeutic window for bactericidal clearance. Finally, we have polymyxin B at an intermediate MIC of 1. In years past, this would have been our Hail Mary, but given the toxicity profile and the superior options we now have in cefiderocol and Ricarbrio, the polymyxins should remain strictly on the bench for this patient. My clinical recommendation is clear. Given the intermediate status of Zerbaxa and the potential for rapid MIC creep, I would move directly to cefiderocol. With an MIC that low, it is the most stable and potent weapon we have. Alternatively, imipenem relebactam is a strong contender if cefiderocol is unavailable, but I would ensure we are using the optimized dosing of 1.25 grams every 6 hours. In cases like this, we don't just treat the bacteria, we outsmart their mechanics. We use the siderophore system, or the novel diazobicyclooctane inhibitors, to crack a shell that traditional drugs can't touch. This is precision infectious disease management at its best.